Thank you so much for the invitation to present. It's sunny in Sydney, which is a great difference to Melbourne, which is blowing a gale today. So my topic is aortic surgery in adult congenital heart disease in 10 minutes, no less. And as you can see from the list on the right here, potentially there's quite a lot to talk about. There's a whole series of things that happen to people's aortas that they can inherit. We haven't talked, and is not on the program, about aortopathies and bicuspid aortic valve disease. And if anyone has any questions, we can talk about them later. We've addressed some of these ones in the middle, such as coactation, and I was going to talk a little bit about CONOTRUNCAL abnormalities and some of the more complex things that we've been doing at the Royal Melbourne. So I thought, just to illustrate the sort of stuff that we do, here's a typical case over on the side here. You can see a CT scan of a man who's got an aortic root aneurysm, and it's not just any aortic root aneurysm. He had a Ross procedure as a teenager. He subsequently had an aortic valve repair. He then moved on and had a mechanical aortic valve replacement, and now has an enlarging aneurysm of his aortic root. So the typical patient that we're seeing is someone who's had multiple redos, often can have quite complex coronary anatomy. In this case, this man's left coronary button was stuck to the base of his calcified pulmonary homograft, which has created a lot of fun, and often the presence of other conduits and repairs. So it's quite a complex area. So I thought just briefly in my 10 minutes, we'd go over a very quick evolution of adult paediatric surgery, because it really informs what we're doing today, and then have a look at this particularly complex CONOTRUNCAL group and maybe anticipate some of the challenges that are coming around the corner from our colleagues down the road at the Royal Children's. So it was mentioned before that the original paediatric surgery was really palliative things, doing shunts and banding and so on, and it evolved with the evolution of cardiopulmonary bypass. And so the simpler things that were referred to earlier, ASDs, VSDs, tetralogies, were repaired. And we've heard lots of talks about some of the long-term issues that occur with these patients. But it's really the evolution in the 80s that changed what we're doing today. So the Royal Children's surgeon in the 80s began to correct transposition with the arterial switch, which was first done in 1983, correcting truncus arteriosus, and then later hyperplastic left heart syndrome. And so these children who really struggled before, had the atrial level switches, were getting switched in the 80s. And so it's changed our spectrum of adult surgery. So in the early 2000s, adult congenital heart surgery was lots of secundum ASD repairs that we've seen our colleagues, the cardiologists, have nicked, which is a shame because they're fun. And pulmonary valve replacements, the odd coactation and Ebstein's. And that's really evolved over the last few years, so that we're still doing the pulmonary valve and conduit changes, but what we've started to see is aortic aneurysms in a really complex group of people. So people with congenital aortic stenosis, people who've had Ross procedures in the past, not done with our technique, and the CONOTRUNCAL patients. So Yishay touched on this, but we'll go over it again, that the heart develops as a tube, and the aorta and the pulmonary artery develop out of a single tube, the truncus arteriosus, that splits into two. And if you get an abnormality in the splitting into two, then you end up with one of these defects. So the transposition is the one that's been described earlier, the double outlet right ventricle, that it's enough to know its name, truncus arteriosus and tetralogy are all part of this group. So we heard a lot about tetralogy earlier, about the change in the position of this part of the septum. But what's important to realise is because this part of the septum moves over, all tetralogy patients, or nearly all, have an enlarged aorta to begin with. Now, we don't know the natural history for everybody as to what happens. We know that all of them, or nearly all of them, develop pulmonary valve problems and right ventricular problems, but there are a group who develop aortic root dilatation later in life, and they end up with aortic valve regurgitation. Similar with the truncus, because the aorta and the pulmonary artery develop as the one vessel, and the paediatric surgeons divide the vessel here to construct a pulmonary outflow tract and an aortic outflow tract, the aorta begins too large at the start of life, and it can grow over time into a significant aneurysm. And the tetralogy patients, the TGA, the transposition patients, when you think about an arterial switch, the patient is born with a left ventricle that leads to the pulmonary artery and a right ventricle that leads to the aorta. When these are switched over, the aorta comes off the left ventricle, but that's actually still the pulmonary valve and the pulmonary root that stays in the patient. So in the systemic circulation, they have the wrong valve and the wrong root tissue, and that can cause problems down the track. We heard Yishay talk about the Lecomte manoeuvre, which is where the pulmonary artery is moved anterior to the aorta, and that may cause problems in redos down the track. And here's the scan of a patient who has had a previous transposition. There's the aorta, and there's the aortic aneurysm, and there's the pulmonary artery draped right over the front of it. So there certainly are some extra challenges in these patients. My colleagues at the Royal Children's have an enormous experience in this operation, and they have fantastic long-term outcomes. And my current registrar wrote up their experience and commented that their arterial switch patients have really had outstanding long-term outcomes and very little problems with their neo-aortic root. But I think they've probably made their call a bit early, and I think we're going to see a lot more of this as time goes on. One of the issues, and when this is mentioned at conferences, a lot of the questions revolve around when do we operate on these people, because we know very little about the natural history. We don't know exactly when the tip-off point is in terms of their risk of problems. So most of the time when we see patients with these problems, they have progressive aortic dilatation. It nearly always, not always, but nearly always goes with a significant aortic valve regurgitation. So there's a combined indication for surgery. Right ventricular outflow tract obstruction, other valve failures can go along with that. But there's also limited surgical outcome data to guide us as well. From a surgical point of view, there are some significant challenges. One is access. And you can see here, this is a patient with truncus arteriosus, and this is a pulmonary conduit. You can see the white is the calcification within the conduit, and it's stuck just very nicely to the back of the sternum. So reopening the sternum in some of these patients can be pretty hazardous. Cannulating for cardiopulmonary bypass and finding access, particularly if people had lots of catheters as children, they often don't have good femoral access, that can be a problem. The coronary anatomy can be nothing like normal, particularly in the switch patients where the arteries have been transposed, the switch root can grow asymmetrically, so the diagrams and descriptions of the previous surgeons often don't help us to know where the arteries are going to be. And one of the things that hasn't been touched on an enormous amount is the valve choices that we make, particularly in young women who are anticipating families, and particularly in young active men and women who are playing sports and doing high-risk activities. So in terms of our experience at Royal Melbourne doing these operations, it's myself and subsequent speaker Peter Skillington. We've done 26 of these cases. As you can see, it's a mixture of tetralogy patients, people who had transposition and had a switch, a group with truncus and some double outlet right ventricles. And nearly all the patients did have quite significant aneurysms. So the mean was nearly 60 millimetres, ranging between 40 to 80. And again, nearly all of them had quite significant aortic valve regurgitation, a bit of one with stenosis and one with mixed disease. Nearly all the patients we've done composite mechanical valve graft Bentel type operations. So we've replaced the aortic root with a Dacron graft. Nearly all of them have been with a mechanical valve that comes as part of the valve graft conduit. One patient had a Ross procedure and one patient a valve and ascending aortic graft. As you can see down here, there are quite a lot of other procedures that go with it, however. So pulmonary valve replacements, conduit replacements, reconstruction of pulmonary artery stenoses, and so on. And indeed, we've had a couple of patients who've had a root procedure done subsequent to their switch. Then they have Dacron in their root with the pulmonary artery folded over it, and then the pulmonary artery often gets injured and requires significant reconstruction. The results have been outstanding. We haven't had any deaths, a single reoperation for bleeding, and no other significant morbidity. So they're a group of what are essentially young patients having complex surgery, but they are very well patients generally. One of the questions that really is very difficult, I think, is the indication for surgery, because we don't know the risk of dissection or rupture in these patients. When the valve goes, it makes the decision to operate easier. We don't have any natural history data on the rate of growth. But then there's competing issues. So on the right here, this is not a patient with congenital heart disease. It's a patient with a 10 centimetre ascending aortic aneurysm. That's a bit of a challenge to manage. It'd be an even bigger challenge if the patient had severe aortic regurgitation, had had 4 previous sternotomies, if something was stuck to the back of the sternum here, and suddenly you've got a really dangerous operation. So I think there's competing risks about safety of your surgery that you're going to have to plan versus the natural history of a disease that we don't necessarily understand too well. So the conclusion is that at this stage we're going to see more patients coming through with more complex pathologies, and the practice of adult congenital heart surgeries we've all alluded to is becoming more complex, and aortic surgery is going to continue to evolve. But we have a few challenges coming up, I think. The first is extra anatomical bypass for coarctation, which is something our colleagues down the road have got into for complex coarctation, is to run a graft from the ascending aorta through the pericardium to the descending aorta. Now we know there's a significant incidence of bicuspid valve disease, and these patients are going to come back for aortic root and aortic valve intervention, and I think this is going to be a real challenge. but nothing like what's going to happen when our Norwood patients grow up. So that people with hypoplastic left heart syndrome at their initial operation have an aortic arch reconstructed with a variety of materials and can end up with some pretty amazing looking aneurysms. I haven't yet seen one of these. I haven't got to the age cohort that we've had to tackle them, but my friends tell me they're very challenging. So I look forward to that. Thanks for your attention.